All, this is Dr. Mobeen Sayed. Here is an interesting study that I wanted to discuss. This is published in the Lancet. The study is entitled Vascular and Inflammatory Diseases After COVID-19 Infection. So, vascular and inflammatory diseases after COVID-19 infection and vaccination in children and young people in England. A retrospective population-based cohort study using linked electronic health record. So the way they did the study is that they had about 14 million UK children. That is said to be about 85% of their population. And what they did was they looked at the absolute excess risk of myocarditis in those children who got COVID infection versus myocarditis in children who got vaccinated. So what did they show? Let me actually show you the results first, and then we would look at the some of the, I believe, weaknesses in this study. So here is the study, vascular and inflammatory diseases after COVID-19 infection and vaccination in children, young people in England. There is an errata as well. You can look at that. However, I want to show you this one. Let me see if I can increase in size. So if we read here, the 6-month absolute excess risk for myocarditis or pericarditis, so they kind of combined them together, were 2.24 per 100,000 individuals after diagnosis versus before diagnosis or undiagnosed. So what they're saying is that those children who did not have infection, when they were compared to the situation when they had infection, COVID diagnosis was positive, and then if you count the myocarditis in undiagnosed or non-COVID infection state versus in the COVID infection state, then the excess risk of myocarditis was 2.24 per 100,000 individuals with infections. Compare that to the vaccine. In the case of vaccine, it's similar number said. So vaccinated versus unvaccinated, 100,000 vaccinated, 0.85 myocarditis cases per 100,000 vaccinees in the first 4 weeks. Then the risk drops even more. So of course, what is the conclusion here? The conclusion is that COVID infection almost has double, triple the risk of myocarditis compared to the vaccine itself. So this is the basic idea of the study. There are some more details that you can look at. It's a retrospective study. So they're looking back in the data, they're looking at the health record in the UK, and then they have certain terms. For example, the COVID infection, they only see the first event of the infection. And the infection, if you go down here to exposures, here we are at exposures. COVID-19 diagnosis, excuse me, was defined at the earliest recorded date of positive COVID-19 PCR or antigen test or a confirmed COVID-19 diagnosis in primary care or secondary care hospital admission records as defined in the previous analysis. So of course, over here, the test themselves, we would assume them to be 100% accurate, but we know that PCR or antigen tests or other tests can have gaps in their accuracy. But this is their definition. So the first infection only. Similarly for vaccination, this is very important to note. COVID-19 vaccination was defined as a record of the first dose of the BioNTech mRNA, so that is Pfizer BioNTech, in the UK. And that was the vaccine first dose only. Right here, you would actually feel or know something, and that is most of the myocarditis occur after the second dose. But here they only counted the first dose, or they only counted after the first dose. Then there is another interesting thing they did. That was the infection cohort, meaning those who were infected, comprised children with or without COVID-19 diagnosis. So that means that cohort had uninfected children and infected children to compare. And the vaccination cohort comprised children with or without vaccination. So unvaccinated children and vaccinated children. These two cohorts are not mutually exclusive. So somebody could have vaccine and infection, and they both events will be held separately, and any association with myocarditis will be held separately. To allow for independent estimation of risks following each exposure, follow-up time was not censored by the other exposure. So imagine if I had vaccination and then 2 months later I had infection. That event of infection will not cancel out the vaccination monitoring window. So you would continue to monitor for vaccine and keep giving the time to vaccine cohort, while now this child is also in infection cohort and the time is also going to infection. Then if the myocarditis occurs, this may occur, let's say, another month later. So now this myocarditis can be counted in both the infection and vaccination. And when they'll do regression analysis, then the closer event is infection and it will get counted there. So it's an interesting problem. They say in their limits of this study that we were not able to account for combinations, that is vaccine and then infection or infection and then vaccine. And so that is I think, pretty severe limitation. Okay, so with this kind of data, I wanted to share some of the challenges that I think are facing this study. Although it is very popular at this time, almost every media outlet is talking about it, and they are showing it, universities, hospitals. There are lots of discussion. So I want to share some of the aspects of this study. So here are some curious gaps that I see. First of all, you saw the definition of COVID diagnosis. Their definition was whenever the patient was diagnosed either in the primary or secondary healthcare, or when they had PCR positive, or when they have antigen test, etc. So they counted a time when the child was positive, declared positive, or diagnosed positive. That means he or she was in the healthcare system. What happened to those who were asymptomatic, and what happened to those who were not severe enough and were at home? Now, the interesting problem is that what is the count of asymptomatic? Because when they're having these counting issues, if they have the counting issues, then what are those issues? So they have for sure counted those who ended up, the children who ended up interacting with the healthcare system and got themselves tests or diagnosis, but those who are asymptomatic, they are not counted in it. Those who are at home is a question mark for me, that how did they end up? Did they end up with some kind of a random survey? For example, if you stand on the road and you start doing the surveys, and then based on that survey, you extrapolate the numbers to everyone, or not? They do talk about the end of the surveys and the numbers, but I think there is a confusion in here. So let's leave the at home part for a second. If we just take the asymptomatic part and say that that is not counted, then we would seek out to figure out what is the asymptomatic part. And then I wanted to share a study here. This is a study, this study. Let's actually go to that study. So look at this study here. The asymptomatic fraction of infection by age group were 52% for 0 to 4 years of age, 50% of asymptomatic infection in 5 to 11 years of age, and 45% in 12 to 17 years of age. Where did this study come from? This is not the UK study. This is incidence rates, household infection risk, and clinical characteristics of SARS-CoV-2 infection among children and adults in Utah and New York City, New York. And if you look at it, this is December 2021. So it doesn't cover the whole time of the UK study, because UK study went from January 2020, the beginning of COVID, up to December 2022. So it went from the alpha, and then even delta. This study actually is showing the numbers for up to 2021. So 1 year lesser than the vaccine study. Plus, it's a different territory, it's a different geography, it's a different country. So you could say that, hey, I'm not going to look for this number, but this is what we have. Similarly, there is another study that is, I think this is the study, this is from Ghana. They said, and if you look at it, received January 2024 and blah. So this is March 21 to June 2022, kind of 1 year of overlap with the UK study. And here they said the asymptomatic infection was about 84%. So if you look at this, 84% of RT-PCR positive infections were asymptomatic. So I would say that anywhere from 30% to 70-80%, depending upon what the territory and the situation in those areas is. But a short of this all is there is a cohort that, in my opinion, has been missed, which is asymptomatic. Let's say for our number, we call it 50%. Just you can decide to call it 10% or 0% or say it's already included. But let's say 50%. If it is 50%, then all the risk numbers actually become half because their counting of the total infections is wrong. So that is one issue with the counting. Then the question is at home part, this part. And you know that there is a very sparse data or almost unavailable data for how many children became infected and stayed at home, were symptomatic but stayed at home. So the only one way to get an idea, and this is a Norwegian study, so that once again does not apply to UK study, so it can be dismissed based on that. But if you see here, they say children aged 1 to 5 years who tested positive also showed a minor long-term relative increase in primary care. So they were using the usage of primary care by a cohort of patients to understand how severe their problems were. Did they go and interact and receive medical attention? So children who were infected and were within the age of 1 to 5 years, they only used about 13% of the medical resources. Compared to those who were not infected. The children who were infected had 13% additional usage of medical resources. That also tells you that a huge number of children must be at home and asymptomatic and symptomatic and at home because the usage of medical resources was not too much. So this may give us an idea, but this is not exactly the answer for how many children were at home. So in our count, this number is still a mystery. I'm sure I have actually sent an email out to authors to say that can you please answer or enlighten us for these, and I haven't received a response yet. It's more than a couple of days. We'll see. Then this is an interesting and curious thing for me. It is said that from Pfizer BioNTech, especially in boys, children, men, male children, the risk of myocarditis is actually highest after the second dose of the vaccine. And as I showed you the definition of COVID vaccine in this particular study, the vaccine definition was the first dose of the vaccine. And they said we did not look at the repeat exposures and we did not look at the combinations. And I would actually show it to you. And they actually admit that that is a limitation. So if I go down to their limits in the study here, look at this. Only first COVID-19 diagnosis and vaccination were considered and not repeated exposures. So second dose, third dose, fourth dose, whatever, they did not count them. The second infection, third infection, they did not count them. Similarly, if you look at the fifth limitation, we did not account for subsequent or combined exposures, whether reported or unreported. So I have a vaccine and a month later I have infection, then I have myocarditis. Where does that go? It is not going into the combined bucket, and that is a problem. But anyways, they are clear about it in their study limits. So here, I thought I'll actually bring you some studies for how the second dose has the highest risk. And I found this on Pfizer's own site. This is Pfizer. Pfizer says the highest risk of developing myocarditis has been identified in young males within 14 days post vaccination after the second dose of the primary series of vaccination with an mRNA vaccine. After the second dose. In this study, what did we count? After the first dose. Furthermore, analyses of data from the US Center for Disease Control and Prevention from the vaccine adverse events indicate that myocarditis after a booster vaccine dose is less common than after the second dose. So second dose is a very important dose because it has a risk there. Is that counted? So the question to say that, let's say this is the vaccine here, first dose. Then this is the vaccine second dose. Then here is the myocarditis. How is this myocarditis counted? Is it, of course, we're not counting the second dose. So this myocarditis occurred after the second dose. Are they going to actually just count it as the one after the first dose? If that is the case, then it is a misclassification. Or did they just leave it as baseline? I do not know. I have sent them the question to say, can you please tell me, how did you count this? But here, the second dose that was important is not counted. Similarly, these combinations, and I showed you the limitation number 5, the combinations are not accounted for. So vaccine, then infection, then myocarditis. Where is this myocarditis counted? Because it is not counted as vaccine count continues, infections monitoring continues, myocarditis occurs. My suspicion is this myocarditis will be counted in the infection because that is the closest event. If that happens, this myocarditis is actually incorrectly attributed to first infection. Similarly, what happens when this is vaccine and myocarditis second dose? They said we do not work with the repeat. So the best comparison. So imagine that we are doctors. We are sitting with a mother who is asking for the risk for their child. She's going to say, what is the risk to my child for myocarditis if I get the vaccine versus if I don't get it, and what is going to happen from the infection? So we say, all right, for the infection, we know that there is no vaccine and the infection is, the count of infection will be people, kids at home, asymptomatic or symptomatic, then kids that came in the outpatient, and then kids that ended up in the hospital. You count them all and you see the myocarditis rate in there, and that is how you count the incidence. Do we have that number from this study? No. We only have the number if the child becomes sick enough to interact with the healthcare system. So this, we don't really have a very good idea, but from this study's point of view, you'll say 2.24 compared to uninfected. Now she says, okay, so if I got vaccinated, my child, then what will I have? And imagine for a second that the vaccine has no side effect of myocarditis. No side effect of myocarditis. That means you as a physician will say, all right, after the vaccine, the risk of getting infected will reduce. It will not go away. It will reduce. And the risk of severe infection will reduce. It will not go away, but will reduce. So the mother would say, okay, how much reduction? So this study doesn't talk about it. So I'm going to make up a number and I'm going to show you a study later on. Let's say that we say that without the vaccine, if the child becomes infected, then out of 100,000, there is the risk of 2.2 or excess risk of 2.24 myocarditis per 100,000 children. After vaccine, if these children get infected, then out of 100,000, instead of 2.24, it is now 1.5. So the mother becomes happy and says, all right, very good. That reduces the incidence. And so I'm going to vaccinate. Then she says, what do you think? Is there any side effect for the vaccine? And you say, yeah, sure. The vaccine itself can also be linked to myocarditis. So soon after the first or second dose, there could be myocarditis because of the linked to the vaccine. I'm deliberately trying not to use the word causal because, so linked to the vaccine. And so she says, okay, I have 1.5 already, the risk. And what is the vaccine's side effect risk of myocarditis? And you say, well, that is 0.84. So now she has to say, all right, 1.5 plus 0.84 is the final total risk. And then she has to compare that to here. Do we have this number in this study? No. Do we have a correct number for infection? No. So once again, the study itself is kind of not there with the numbers. Similarly, there is another very interesting thing, and that is that on day 0, myocarditis is hazard ratio for myocarditis is higher than the next week's. So let me show you this. This is actually very interesting. This is their supplemental table. This is the supplemental table number 9, COVID infection. So if you see here, myocarditis, pericarditis, maximally adjusted, day 0, look at the rate, or hazard ratio, 63.24, day 0. Then 4.45, then 2.24, then 0.54. In the coming weeks, week 1 to 4, week 5 to 26, and then 27 to 52. So first month, 6 months, 1 year. The first day is the highest. Why? Because it is possible that a child who ended up in the healthcare system may actually have developed the myocarditis from the infection and went there, and the day 0 they found the infection. Or this is also possible that a child had a myocarditis event and ended up in the hospital because of that, and they accidentally or coincidentally found COVID-19 infection too. Did the authors and the researchers kind of account for that? I did not see it. Maybe they did. So that is also a very curious thing that is present in the study. Then here is the most interesting thing. I think that the second dose is a very interesting thing that is missed, and the asymptomatic cases is a very interesting thing that is missed. But there is even more interesting thing, and that is if you go to the table number 16, supplementary table number 16, this one, it actually has these numbers. So this is amazing. How this is amazing is they looked at the infection cohort. We started from January 2020 and went up to, I believe, December 2022. So in this cohort, they had smaller groups. So for example, if you see here, this is the myocarditis, pericarditis in the infected children age 5 to 18 years, January 2020 to May 2021. So starting from the January, almost in the middle is June, but this is May, almost in the middle of 2021. So almost 1.5 years, right? What is the absolute excess risk? Check this out, 3.3, 3.3. Then if you look at children from June of 2021, different variant, it's kind of Delta time. Previously it was Alpha and others. Now we are shifting towards Delta. So you go to Delta, same children 5 to 18 years, June 2021 to March 2022, look at the myocarditis excess risk, 0.45, 0.45 compared to 3.31. So what do you think we should do? Or authors, or we should all at least be able to see, we should be able to see that, hey, as the COVID infection continued, as the pandemic continued, the risk of myocarditis reduced. Why did it reduce? Did they all become infected and protected, or vaccinated and protected, or was it because the variant became weaker, or this was a combination, or people were doing lockdowns, whatever it was? In the second part of the cohort, the myocarditis after the infection was 0.45. And look at the myocarditis after the vaccine, 0.85, 0.85 after the vaccine, and 0.45 after the infection. And there is one more myocarditis over here. This is the one they used. They used the whole size of it. That is January till May or March 2022. They used the full window, and the full window's number was 2.24. They used this number, which is fine. I mean, you can't go and blame them that why did they use that number. They can say, well, we counted the, you know, we ran the study for this long, and so we have a right to look at the whole number. Fine, but they did not show this thing. So it almost becomes half of the vaccination if you look at the second part of the cohort for infection. So that is very interesting for me. I'm sure that they have an explanation. So if you see here, same thing. They used this number and this number for vaccine. They ignored this second part. Similarly, they have some other similar numbers as well. Then, final thing, this one, they made a comment here. They said, however, no increased risk was observed beyond that period. So let me read the whole thing. By contrast, COVID-19 vaccination was associated with a short-term increased risk of myocarditis or pericarditis, mainly within the first 4 weeks of vaccination. However, no increased risk was observed beyond that period, and there was no evidence of long-term myocarditis signal after vaccination. This is what they're saying. So I wanted to show you some studies. So here is a study, and I have actually discussed this study before. This is the Journal of Pediatrics, persistent cardiac magnetic resonance imaging finding in a cohort of adolescent with post-coronavirus disease, mRNA vaccine myopericarditis. Again, this is not UK study. This is actually a US study. But look at the findings here. They say all patients underwent, so these are the patients of, these are children who got vaccinated, then they developed myopericarditis, to which the UK study is saying that after four weeks, there was no further signal and no idea of the myopericarditis. This hospital is saying that we followed up with the children for 3 to 8 months after their initial study. The results are compared in the table. So what did they say? They said, follow-up cardiac MRI, left ventricular ejection fraction was significantly improved from initial, and none of the patients had regional wall motion abnormalities. Very good. So their wall, the heart wall, was not abnormal. Left ventricular ejection fraction by echocardiogram was normal for all patients at the time of follow-up. So their ejection fraction, the heart was pumping correctly. Now check this out. 11 patients, 68.8%, had persistent LGE. So they had persistent imaging signs in their heart for pericarditis, myocarditis. Although there was a significant decrease in the quantifiable LGE from the initial study. Cardiac edema resolved in all but one patient. So here we are just talking a very small number of patients. Imagine the UK study, which is saying 4 million children who were infected, 4 million almost children who were vaccinated. Here we are looking at a study that is only few number of children. And even then they're saying one child 3 to 8 months later had not had the edema resolved. Then they say global, where did it go? Sorry, I wanted to increase the size. Okay, so then they say global longitudinal strain on the heart remained abnormal in most patients, 75%. This is 3 to 8 months later. At follow-up without significant change from the initial study. So it may be that the UK children, I mean, I would wish them that they are fully recovered. So maybe the UK children, that geography, that environment is such that they actually all recovered within a month. But here is one study. Here is another study. Long-term cardiac function and symptoms in patient following COVID-19 vaccination myocarditis. Here it says, and this was actually, the patients are not necessarily children. 46 patients. Myocarditis most frequently occurred after the third COVID-19 vaccine, with 14 patients developing myocarditis within the 13 days. The median time since admission was 2.4 years. At follow-up, 11 patients had a left ventricular ejection fraction of 50% compared to 14 at admission. Right? So there was a deterioration 2.5 years later. But that is for adults, not children. So I have to be fair. Children have a better possibility for repair. Their hearts are growing, their body is growing, so they can repair better. The incidence of myocarditis and pericarditis in post-COVID-19 unvaccinated patients. This is actually an interesting study. I'm not sure how good it is, but the study actually says that they found no post-COVID-19 infection was not associated with either myocarditis or pericarditis. This is an Israeli study in which they say, and I usually think that Israeli studies are good studies, but anyways, in this study, they say we did not find any myocarditis, pericarditis after the infection. That I think there are many studies that credibly show that myocarditis, pericarditis can occur after the infection. So this is the discussion. Good study, 14 million children, about 4 million vaccinated, 4 million infected, their comparisons. That is cool. And it is a very popular study at this time. But there are some limitations they themselves acknowledge, and some counting issues, some comparison window issues, I think are just, maybe they just don't have enough resources to look at all of those things. But these are interesting challenges, I think, for this study. So this is the discussion. Thank you very much for being here, and I would see you next time. Bye for now.